Is my skin visible?
Yes, ma'am.
Okay.
So welcome everyone to the DOS post-graduation education program. We did stop our activities last week in view of everything that's going on, and we will keep that message up in the front, but we're returning to our academic activities. Today, we have a wonderful lecture by Dr. Joyeeta Das. I'm just going to make a quick introduction. I'm Dr. Pallavi. I am in private practice in oculoplastics. Dr. Puneet Jain, he's a senior consultant at Sharpsight Eye Hospitals. He does oculoplastics over there. We both have been coordinating these series. And let me introduce our speaker for the day, Dr. Joyeeta Das, who is a senior consultant at present at Disha Eye Hospitals in Calcutta. And she's been previously at Shankar Eye Hospital, Sadhguru Netra Chikitsalaya, and she has multiple publications in high impact journals like IGO, Orbit, OPRS, and she's been a reviewer for these journals as well. And she's won multiple awards for her videos and her publications at the American Academy of Ophthalmology. And she's going to talk about, I think, a very important topic today, especially from the exam point of view, about malignant lid tumors. So without any further delay, ma'am, I will hand over to you.
My screens are visible?
Your
Hello.
screen, you can start sharing now, ma'am.
Okay, just a minute. I'll just share it.
Yeah, because I think, yeah. Your screen is visible now. I think you can go into
Yes.
full screen mode now. Yeah, perfect.
Okay. Very good evening to all of you. Thank you, Dr. Pallavi, Puneet, and the whole DOS team for the kind invitation. Today, I'll be talking on malignant eyelid tumor. This is a very important topic, both in practice and also for exam. Every day, we used to see many kind of eyelid tumors ranging from a simple sebaceous gland, sebaceous gland cyst to carcinoma like basal cell carcinoma and any other. However, the eyelid tumor is the most common place of skin cancer. Just a minute. Eyelid is the most common place for skin cancer to occur, and eyelid cancer carcinoma constitute for 5 to 10% of the all skin cancer. The most of the tumors are benign, ranging from 82 to 98% tumor are mostly benign. However, the rest are the malignant tumor. However, the consequences of misdiagnosis of malignant cases are significant. So we always is significant. So we have to learn, or we have to make our eye clear that what to diagnose what is a malignant tumor, if the tumor what we are dealing is malignant or not. So the main goal is to rule out malignancy. The characteristic of malignant lesion are ulceration, that is loss of or non-healing surface or epithelium of the lesion. Second is induration, that is thickening of the lesion. Next is pearly border, irregular margin of the asymmetric shape. Irregular margin, you can clearly see the margin irregular in this type of lesion. And how to assess the asymmetry? If you draw a vertical or horizontal line, the mirror image is not, there is no mirror image. That is, both sides are different. So this is asymmetry. And telangiectasia, this is also a very much characteristic sign of malignant lesion. Telangiectasia mean there is tortuous thickened blood vessels over the mass. This is very characteristic of a malignant lesion. Next, important findings are architecture of the lid margin is distorted in malignant lesion. You can see here, once you lift the lid, you can see the margin is distorted. There is loss of lashes, and also the gray line or the roots are not visible. The glands are not, roots are visible. And the characteristic of benign lesion, as you all know, these are usually slow growing, having well demarcated border. They are translucent and they have an intact epithelium, and they are evenly pigmented, not as irregularly pigmented as we see in basal cell carcinoma or melanoma and any other tumor. So a classification of eyelid tumor, we can tumor, we can classify it as a origin of the tumor. That is, first is or the tumor which are origin from the epidermis of the skin. These are again classified in divided into two types: non-melanocytic and melanocytic. Among the non-melanocytic tumor, papilloma, seborrheic keratitis, these are the benign tumor of the lid which are derived from the epidermis. And among the malignant one, there are basal cell carcinoma, squamous cell carcinoma. And the melanocytic tumor, that are pigmented tumor, these are nevus, this is the benign type, or malignant one is malignant melanoma. Next, come to the tumor of the lid, which are arising from the adnexal and the cystic, and it forms usually cystic lesion. These are some tumor which are arise from the sebaceous glands of the eyelid. These are benign sebaceous gland adenoma, or it could be a deadly sebaceous gland carcinoma. There are some tumor which also arises from the sweat gland. These are syringoma, sweat gland, syringoma, hydrocystoma. There are many other glands which are most are common. There are many commoner syringoma. And next is sweat gland carcinoma or eccrine adenocarcinoma, sweat gland mucoepidermoid carcinoma, etc. The eyelid tumor which arises from the hair follicle are trichoepithelioma, pilomatrixoma, and carcinoma of the hair follicle. This pilomatrixoma is actually a benign tumor. However, it has a high potential for malignancy. The other tumor, which are cystic tumor, are cyst of G's and mole, epidermal inclusion cyst, and epidermal inclusion cyst, etc. These are, I think, already covered by Dr. Puneet in the last class. So there are also some muscles. So from the muscle, the tumor which originates from the muscle in the lid are leiomyoma, leiomyosarcoma, rhabdomyoma, and rhabdomyosarcoma. These are the malignant tumor of the muscle origin. However, in our common practice, we see the malignancy of eyelid tumor, you can still divide it, which we will discuss in this lecture, are basal cell carcinoma, sebaceous gland carcinoma, squamous cell carcinoma, and malignant melanoma. Though malignant melanoma is among the rare tumor of the periocular region. In the Western population, we see basal cell carcinoma is the most common tumor. This is very important to note. However, in India and other Asian population, sebaceous gland carcinoma are the most common tumor, followed by basal cell carcinoma and squamous cell carcinoma. This is a nice article from 2020 from Dr. Rasmi Gupta, Dr. Bhaduri et al. And they have compared the lead malignancy across the world. And here you can see in the Western literature, the basal cell carcinoma is the most common, whereas in India, the one article from LBPI, you can see the basal cell carcinoma was 24%, where they have found sebaceous gland carcinoma among is the highest, among the highest, prevalence is highest. But this current study, which I am quoting here, is a multi-center study from various part of this country, India, and they have shown that basal cell carcinoma here are among 36%, followed by sebaceous and squamous cell carcinoma. So, if somebody asks what is the most common eyelid tumor, then we have to mention both. In Western population, and it is the basal cell carcinoma, and in the India and the Asian population, it is the sebaceous gland carcinoma followed by basal cell carcinoma. First, come to basal cell carcinoma. This is the commonest malignancy of lid in Western countries, however, not in India. And in other Asian countries, in India, the prevalence is around 30%, where in other Asian countries like Korea, China, it is around 36 to 40%. What are the risk factors of basal cell carcinoma? Basal cell carcinoma usually occurs in lightly pigmented people who are mostly Irish, English, or Scandinavian in origin. And the next risk factor is sun exposure, especially in the first 2 decades of life. Next is radiation, solid organ transplantation, and it is also associated with some syndrome like xeroderma pigmentosum and Gorlin-Koch syndrome. This is one case of mine. You can see he has Gorlin-Gauss syndrome, which is characterized by multiple basal cell carcinoma in various part of the body. Here you can see in the right eye lower lid, and also in left eye pinna, there is basal cell carcinoma. He also had some jawbone tumor and some rib deformity. So the triad of Gorlin-Gauss syndrome is multiple basal cell carcinoma, odontogenic, that is from jaw tumor, and ribs bifurcation or rib anomaly. This is very common PET question for OSCE. Now come to the location. Basal cell carcinoma most commonly found in lower lid, 50 to 60%, followed by medial canthus and followed by upper lid and lateral canthus. Now come to the histology. It is derived from the pluripotent basal cell of the epidermis, the cell proliferating downwards, and it exhibits a palisading at the periphery. This is the current classification, WHO classification of the basal cell carcinoma of the skin and eyelid, and they have classified the basal cell carcinoma into according to the risk of recurrence. There are some tumors which are low in recurrence. These are nodular type, superficial type, pigmented, infundibulo, cystic, and fibroepithelial type. And among the nodular type, keratotic, cystic, and adenoid are the sub-classification of the nodular. And in our practice, we see nodular is the one of the most common. Next is high risk type of basal cell carcinoma, and they have divided it into micronodular type, infiltrating type, sclerosing or morphic type, basosquamous, and sarcomotive type. These are the rare variety. However, it has high risk of recurrence. These are the clinical picture of nodular and nodulo-ulcerative tumor, basal cell carcinoma, which is also known as rodent ulcer. This sclerosing and morphiform, these are actually had some intradermal proliferation pattern. Superficially, it may seem a small tumor. However, under the dermis, it progresses to the locally. It is progressing locally. This is the example of the very rare variety of basal cell carcinoma. I've seen this patient, operated this patient 3 years ago, and this found to be a type of adenoid cystic type, which usually masquerades with adenoid cystic carcinoma of the lower lid. So now come to the management. Wide local excision with a tumor-free margin is the treatment of choice in this patient. You can see this is the basal cell, suspected basal cell carcinoma. I have marked it around 4 millimeter away from the margin, which are visible. This is after excision, and these are the rhomboid flap, which has been done later after the margin clearance. Other treatment of basal cell carcinoma are imiquimod 5% skin cream, which can be done in very superficial lesion. And next is bismuth, which is hedgehog pathway, which targets the hedgehog pathway, and it is usually reserved for cases which has extensive basal cell carcinoma, which is non-resectable and which is recurrent. Non-resectable, it is so huge that it is very difficult to reconstruct that portion. In those cases, we can use bismuth. However, the problem is it is very expensive drug, and we have to continue it for lifelong. Once you stop the medicine, it is again the tumor might recur. Next is squamous cell carcinoma. This in Western countries, it is the third most common. And India, it is also the third most common type of skin tumor. There are some benign tumor, which is known as keratoacanthoma. However, sometimes this keratoacanthoma has a high potential for transforming into squamous cell carcinoma. So the management of keratoacanthoma should be in the line of squamous cell carcinoma. Squamous cell carcinoma is a very aggressive tumor, and it metastases by regional lymph nodes and perineural spread to the intracranial cavity via the orbit. The risk factor of squamous cell carcinoma are elderly individual, immunocompromised person with HIV or HPV infection. Chronic sun exposure is another risk factor. I have one patient seen recently who used to work in a central factory of titanium plants, and he has developed both OSSN in the conjunctiva and the lid also. This is one 53-year-old lady who presented with rapidly upper lid mass since last 5 months. On everting the lid, you can see there is a irregular papillary growth on the tarsal conjunctiva along with ulceration. So in the examination part, it is very, very important to evert the lid and see the tarsal conjunctival site. This is another 80-year-old gentleman who has presented with the squamous cell carcinoma of the right eye lower lid, which also extend into the orbit. So clinically, you can see there is extension, and also the ocular movement was absent here. So, and this patient, after imaging, we have done exenteration, and now still he is healthy after 5 years. This is one interesting case. You can see this patient has extensive HPV wart all over the body. He is immunocompromised, and in the upper lid, you can see there is a tumor, which ultimately on incision biopsy proved to be a squamous cell carcinoma. So it's very important to, if the patient has multiple extensive tumor like HPV wart, it's very important to do a serology examination for immunocompetency. Next is sebaceous gland carcinoma. It is a highly malignant and potentially lethal tumor of the skin. It is most commonly occur in the eyelid. In eyelid, it originates from the meibomian gland of the tarsals, and these gland from the eyelash root, caruncle, and skin of the eyebrow. There are some typical patients who are usually affected with sebaceous gland carcinoma. The risk factor are elderly Asian female. Sometimes they do have a history of radiation, patient on diuretics, patient with some immunosuppressants, and systemic and a patient with some other systemic syndrome, like in Muir-Torre syndrome, which is an autosomal dominant syndrome, which is associated with tumor of sebaceous origin in GI system, urologic system, endometrial tissue. Sebaceous gland of the eyelid location-wise, you can see this is most common is upper lid, followed by lower lid, both eyelid, and least common location is caruncle. And if you see the tarsal conjunctival involvement, most of the around 20% cases are the tarsal conjunctiva is normal. Ulceration found in around 65% cases, and ulceration along with overgrowth, a tumor like mass formed in the tarsal conjunctiva in around 25% of the cases. So it's very important to look for the tarsal conjunctiva when examining a patient. We have to evert the lid and look for involvement of the tarsal conjunctiva. And among the skin involvement, 65% patient have normal skin, whereas the telangiectasia and ulceration was found in and around 20% of the cases. Sebaceous gland carcinoma often is a great masquerader, and it is often confused with some benign tumors like chalazion. The most common masquerades are chalazion. And next is unilateral chronic blepharoconjunctivitis. Elderly patient with blepharoconjunctivitis not responding to common the basic empiric treatment, we should suspect some basal cell carcinoma. So we should think of that line. The incidence of misdiagnosis of sebaceous gland carcinoma as chalazion is as much as 20 to 25%. So we have to know when it is not chalazion. We should suspect that it is probably not chalazion when the patient age is more than 40 years. It is a recurrent lesion not responding to empiric therapy like hot fomentation and blood antibiotic, etc. There is presence of lid thickening. The lid margin is thickened, and rounding of the posterior margin of the lid. The posterior margin usually sharp. However, if there is sebaceous gland carcinoma of the meibomian gland or the other tarsal gland, then there will be rounding of the posterior margin. The sharpness of the posterior margin will be abolished, and there will be madarosis, that is loss of lashes. Telangiectasia, some tortuous blood vessels will be there. And the meibomian gland orifices also either abolished or it may look abnormal. And next point is the mass. It is extending beyond the height of the tarsal plate. So if it is there, so the mass is probably, it is not Calazian. And we should think of it is in a line of a management of a sebaceous gland carcinoma yet. The treatment option of eyelid tumor, we have many other options. First is say biopsy, for which is usually reserved for benign tumor, incision biopsy or punch biopsy, and full thickness excision of the lid. This is the chart I can see. In this tumor, there is a diffuse tumor which may look like a benign tumor, but it is not possible to do a wide local excision in the first attempt without confirming the biopsy. So incision biopsy was taken, which includes both the mass and along with the peripheral normal healthy skin. This is the requisition paper what we use in our practice. Next, other option for malignant tumor are wide local excision or surgical excision biopsy, which should be combined with frozen section control of the excision, the tumor margin, or it could be a more microscopy injury. But in our setup, we all do not have frozen section facility. So in this scenario, what I practice that after excision of the tumor mass, the normal tumor margins are taken from biopsy, taken from the normal tumor margin, and also the mass is sent to pathologist, and the pathologist is informed to give the result of the normal tumor margin incision incision. So after 3 to 4 days, they give the result, and we do the local reconstruction in a second attempt. Another therapy like cryotherapy, radiotherapy is also there. When the tumor cannot be resected or patient is not fit for surgery, then we can do this. However, the roles are limited. And lastly, when there is orbital extension, we have to do an exenteration. And the aim of the treatment of malignant tumor is complete removal of the tumor cell with preservation of the unaffected eyelid and periorbital tissue. Before treating an eyelid tumor, we have to classify or grade the tumor or stage the tumor according to the AJCC grading scale. And here also it is the same as any other tumor of the body, like TNM, tumor, lymph node status, and the metastasis is included in this chart. It is available freely in internet, so you can see these details from the internet. So I'm not telling it. And this is the pathology requisition form, where you can usually what we do after doing this after doing the mass excision, the excision biopsy was tagged with a suture, and the normal tissue margin, there is small part of the tissue from the rest of the margin is also taken, and it is labeled and sent to the pathologist. And we also request the pathologist to first clear the the margin status of the margin, and when it is free of tumor, we can reconstruct the lid in the second attempt. And this is how the map biopsy is given. Map biopsy means when we suspect that the sebaceous, especially the sebaceous gland carcinoma, or also squamous or carcinoma, which usually spreads through the conjunctival surface. We have to do a map biopsy to see the pagetoid spread or the spread of the tumor over the conjunctival surface. This is how a small portion of conjunctiva has been taken out from various quadrant of the conjunctival surface, fornix and the tarsal conjunctiva, and it is fixed in a filter paper and sent for map biopsy along with the main tumor section. This is one case. This is a 55 years old gentleman who has been presented with a recurrent history of recurrent chalazion. So we suspect this could be a sebaceous gland carcinoma, but it was quite demarcated. So full thickness lead excision biopsy with a minimum 4 millimeter of tumor-free margin has been taken, along with it is reconstructed with a McGregor flap reconstruction. This is the post-op follow-up after 6 months. This is another case. He has presented with a lower lid non-healing ulcer. In the examination, you can see there is central ulceration. It is a non-tender mass having a pearly white border, irregular pigmentation. So our provisional diagnosis was this is a case of basal cell carcinoma of the lower lid, and mass excision biopsy followed by lid reconstruction was done. This is the 2 weeks post-operative picture, and after the flap division, this is the first stage, and the last. This is the third case with an extensive basal cell carcinoma, which big basal cell carcinoma, which involvement of the full thickness lead which is treated by Hughes. Full thickness lid mass excision, wide local excision with 4 millimeter free margin, and it is reconstructed by freakage transposition flap for the anterior lamella, and for the posterior lamella, Hughes transconjunctival flap from the upper lid was used here. And this is the 6 weeks and 2 weeks post-operative picture. This is another case of a sebaceous gland carcinoma of the upper lid. Here, post-auricular cartilage has been used for reconstruction after the excision of the tumor, and and after confirmation of the frozen tumor-free margin. So just a minute. Yeah. This is another case of recently I have performed the such case. This is an 80 years old gentleman presented with upper lid mass. On eversion, there you can see there is eversion of the ulceration, lid margin architecture loss, and madarosis. So it's a suspicion of an sebaceous gland carcinoma, wide local excision with tumor-free. The tumor-free margin was done, and the lid was deconstructed by Cutler Beer flap. Just a minute. Yeah. Sometimes a benign lesion might also look like a sebaceous gland carcinoma. Like this first case, you can see this patient presented with a recurrent chalazion-like mass for last 6 months. He is a young man of around 35 years. On everting lid, I have seen this is a peculiar type of ulcerated and depressed lesion. So I have suspicion this could be a case of sebaceous. So I have, but seeing the patient age, I thought it's better to do a small incision biopsy before doing the whole excision. And on incision biopsy, it came to be a chronic granulomatous lesion, probably a ruptured chalazion for ruptured chalazion. And this is another case. Here you can see on eversion, you can see there is a pearly white surface with no ulceration. So this is a case of benign tarsal keratin cyst, and it has excised in toto. Sometimes this benign looking mass, this looks like a follicular inverted folliculosis. However, some crustation and that dirty looks, I thought it could be it could be a malignant one. So I have performed a wide local excision with a 4 millimeter margin, and it came to be a squamous cell carcinoma. This is another case which looks like sebaceous gland carcinoma. However, on excision biopsy, it came out to be a simple granulomatous lesion. No Jaden stain was negative, and it is a case of a ruptured chalazion. This is another interesting case. This patient, 70 years old patient, he is an veterinary surgeon, retired veterinary surgeon. He came to me that he is having this lesion and it looks very ugly. So he wants to get rid of that. On first look, I have seen this could be a simple sweat gland tumor like hydrocystoma, syringoma, etc. So I have known, okay, fine, no problem. I'll do excision of this mass. So I've taken that, have done this excision and sent for the biopsy. And surprisingly, this patient is ultimately the biopsy result, to our surprise, it comes to be a diffuse B cell lymphoma, DBLCL, and the patient underwent chemotherapy. Then another rare tumor, which is Merkel cell tumor. This is a very rare tumor seen in eyelid. It is a neuroendocrine type of tumor. Tumors usually originate from the sensory Merkel cell. More than 50% cases seen in the head neck area. The incidence increases with the last decade, like it is usually seen in the aging population, patient with immunosuppression, advanced immunosuppression. Okay. And management is surgical excision. So for any tumor in the eyelid, we should look for, first we should look for any, we have to rule out malignancy first, and then we have to look for step by step for the management. Thank you. Any questions? Now we can discuss the matter.
Thank you so much, Dr. Joyeeta, for that extremely extensive, description of all the tumors. Also, I think the pictures are fantastic, and I would definitely advise to all the residents that if you want to take screenshots, it's a very good idea, because even when you're getting cases during examinations, you have a wide range of all the pictures that Dr. Joyeeta has shown. You have the typical presentations, you have the atypical presentations. So I think it was a fantastic thing. Just a
Sorry,
couple of
I couldn't put any video of the session because my hard drive has been crashed for last 2 days. I'm trying to get out, and this is the just last moment I could arrange the photographs only. So
no,
how to
but I
take the
think
biopsy? Yeah, it is not possible, and I'll try in the next time if I can put some
no, but
videos
I
of
think
how to take.
for residents, ma'am, I think the main thing is because we are mostly looking at it from an exam point of view.
Yes, yes,
So for them to just even like OSCE for spotters, I think it's a
yes,
great,
yes.
it's excellent. Like basal cell carcinoma, typical that, rodent ulcer presentation and all of that. So I think it's fantastic. We have one question from Dr.
Yes.
Sharmishta Behra. I think it's more of a like management sort of a question, because it's unlikely that we'll get a complicated, very complicated case for our exams. But she said that they once had a 45-year-old patient who had a rapid spread following FNAC of a diffuse mass in the lower eyelid. So they did an FNAC, but after that, the patient had a rapid spread, and it was adenocystic carcinoma of the maxillary sinus extending to the lid. So she's asking whether incisional biopsy is justified.
So if it is diffuse mass, incisional biopsy is justified, but FNAC is not the choice of investigation. In FNAC, the tumor cell mostly no, in case of a solid mass, the tumor cell mostly it is not retrievable by FNAC. So FNAB could be a better option, but the incision biopsy is the best option, followed by proper imaging. So FNAP is a better option
If
here,
you
not
could also, ma'am,
FNAC.
explain for the residents a little bit what the difference between an FNAC and an FNAB is, and how we, what is the difference between obtaining both of those samples?
In FNAC, the fluid, the usually smaller bore needle is used and fluid is usually taken out. And in FNAB, it is usually done by a trephine. That is the larger bore needle-like instrument is used to take the part of the tumor, that solid part of the tumor also. But we in lead malignancy lead tumor, usually we do incision biopsy. That is a part of the tumor along with the margin of the skin also, normal skin also taken for the reference. We prefer incision biopsy, not FNAB or FNAC.
So as a rule, I think all the residents should know that whenever possible, you want to get as much tissue as possible.
Yes,
And
yes.
so
And should
obviously if
to
you're
reach the core of that is the epicenter
right,
of the tumor should be taken out. We have to first, we should think that mass as a, 3D, like a 3D. And we should
right.
not miss that center portion of the tumor. So most of the time, we just take the biopsy from the peripheral tissue and the superficial one, which might come as in granuloma or something inflammatory mass. But ultimately, this could be a tumor.
Right. And I think we see that very commonly sometimes, if patients have to be referred to us, this is not exam related, but in
Yes,
general,
yes.
because you will all be practicing comprehensive ophthalmology. So the thing is that you have to understand that whenever you take a biopsy, having enough tissue is the most important thing.
Yes.
Because sometimes what happens is that you ask the comprehensive ophthalmologist to do an incision biopsy so we can do the final reconstruction. And so you make sure that you want to get as much. A lot of times this just happened recently also, that we
And
had a
doing
big tumor
proper
but we got scant
drawing
tissue.
drawing of the, in a requisition is very important for
Labeling.
the orientation of the tumor. And it's very important to communicate with your pathologist. This is very much important, especially when you are doing a private practice, or we are doing practicing in a, not in an institutional setup. This is very
Right.
important to tag with some good rapport with some pathologists who are
Right.
oriented with ocular oncology. It's very important.
And I, like you said, that labeling. So if could you also explain the difference between like Mohs micrographic surgery versus frozen section, or like border, when we get margins, what is the difference between that?
Mm. The Mohs micrographic surgery it's an actually it is we oculoplastic surgeon usually don't do. It is a different kind of technique which takes out the layer by layer tumor, and it is subsequently examined side by side, and up to the no tumor free margin, it is taken out layer by layer. And the frozen section is the from the normal that the excision margin, the tissue from the excision margin is taken out and sent for rapid diagnosis by frozen section technique. And usually it should be present, along with that your operating room, the frozen section system should be present. So it is very difficult to arrange in private practitioners, and also for only ophthalmology setup, like in my hospital, it is not possible. So
I
that's why
think
I usually do
most,
secondary reconstruction.
yeah, I think in most of the setups, but sometimes I remember this used to be like an exam question. So,
Yes.
like you said, in most micrographic surgery, basically what you're doing, you're just slicing layers and layers of skin until you reach a clean,
With a clear.
sort of clear margin. And I think one of the ways to think about it is like, how if you have an apple and sometimes the apple is going bad on the inside. So you're
Yeah.
doing slicing to reach the part where that bad, where you don't have the rotten part. So I think one of my teachers explained it to me like that. And I always remember that that's what
Mhm.
Mohs micrographic surgery is, versus if you're taking a frozen section, you're taking the whole rotten part out and then you're sending an additional clean part just for the lab to check that there is no additional this thing. So I think that is an easy way to remember it. Sometimes this is a question that can be asked in the exam. Anything else, ma'am, that you would like? Puneet sir, do you have any questions
Yes,
for?
yes.
No questions. I was patiently listening to a wonderful presentation by Dr. Joyeeta. So, I think one of the most important slides of your presentation as a PG or as an exam question was the one where you showed that how do you tell, or what are the points that you differentiate between a sebaceous gland carcinoma and a chalazion. So, you did a very nice slide of 7-8 points. I think that is one of the most important slides of the examination, because this question is very frequently asked the moment you get a lid tumor, whether it is BCC, squamous cell carcinoma, basal cell carcinoma, that was always differentiated mostly on the basis of biopsy. So clinical examination, the examiner is looking for simple, simpler lesions. So that is one that one should know all the 6-7 points, how to differentiate between a sebaceous gland carcinoma and a chalazion. And also remember that the management part comes later. The first is how you approach the patient. So, like I highlighted in the previous, we highlighted in the previous lectures also on lead tumors, that approach is very important. So, do not jump, even if you know the diagnosis is straightforward,
Yes.
it is looking like a basal cell carcinoma. Do not jump on the diagnosis and stick to the rules of examination. The next point is that this question is also asked, if it is a very large tumor, then from which part will you take biopsy? So, like you already highlighted, that one should not take biopsy from the edge of the tumor. It will just show chronic inflammation, because in a rapidly growing tumor, all the necrosis and everything is happening on the edges, and it will just show chronic inflammation. So always take a biopsy from each part of the lesion or from the center of the
On the
lesion.
pore, yeah.
When it comes to the eyelid, you can say center. If it is the orbit, then obviously it is a multi-layer incisional biopsy. FNAB and FNAC have no role in eyelid tumors. That's very clear now. So please don't use these fancy terms in exams, because that just degrades your, quality of answer. And incision biopsy is only used if the tumor is not resectable. If the tumor is resectable, then excision biopsy is always the preferred choice of treatment. So in a single line, you can sum up what is the role of incision biopsy: a non-resectable locally advanced tumor, or excision biopsy in a excisable tumor, which can be easily reconstructed, especially if there is no cosmetic angle involved in reconstruction. So
I think this
that's
is a
my
very important point that you mentioned, sir. And I think this is, if there is one takeaway, the fact that if it is resectable, you should do an excision biopsy, because it's very
Yes.
practical questions. Examiners will ask you this, and you should know this. But anything, so I'm sorry, sir, I cut you off. Is there anything else that?
No, I think that would be it.
So, and just to sum up, and I know ma'am had also mentioned it, but just make sure every time you are getting a patient with a lid lesion, malignant or benign, or otherwise, you're always checking for lymph nodes. It should be there in your
Yes, yes.
examination.
Definitely.
Preauricular, submandibular, cervical. These are three areas of lymph nodes you have to check, and you have to mention, because at least clinically you should have an idea that these are the things I'm looking at. You cannot check for metastasis, systemic metastasis, clinically, but at least lymph node palpation is one thing you can do. Anything else, sir, that you can think of apart from just the eyelid examination that we
My
can?
question to Puneet, do you do routine, if you see a suspected large sebaceous gland carcinoma, do you prefer to do in CT scan? Sorry, I'm sorry. PET scan before doing the resection or biopsy? Do you do PET scan? Just
Please unmute her. Yes. Please unmute.
Yeah. Going by literature, the role of PET scan in these lesions is, almost like finding a needle in haystack. But being in corporate practice, then yes, I have to do all these things to be sure. You cannot miss even 1 in 1 million cases, because you might be dealing with that one case. But that would not be my first choice of investigation
yes.
or list of investigation when I'm answering a question in exam. So if the examiner is saying, okay, what more can you do? What more can you do? What more?
Then only.
Then you can say maybe, as a last resort, okay, I might get a PET CT scan because there is an incidence of this much, known or reported metastasis, which is very, very minuscule considering all the eyelid tumors, especially squamous and sebaceous.
But squamous and sebaceous, yes, I agree that there's not as much, but melanoma.
Yeah, melanoma is a
is,
different ballgame.
Melanoma is a
Correct,
different.
So, yeah.
If you
So
get a
that I
melanoma,
think,
then obviously PET scan is
yeah.
the first thing before operating.
But if you're answering in the exam, of course, clinically you will do a PET CT scan, but for all the residents, if you're answering in the exam, always say liver ultrasound first, because most of us are giving, exams and like, you're giving exams to examiners, so they want to know what is the first low-cost modality that you can use that will help to screen. So this should be your mentality while answering a question. You don't straight away jump to the most fancy modern thing. Start with what is simple and then say we'll do liver ultrasound, PET CT and all that. But make sure you don't miss the simple things like, clinical examination and all that when you're answering.
You can, like you said earlier, so you can categorize. So one would be local examination, one would be regional examination, which would be lymph nodes. And then next would be systemic evaluation, which would be investigations like ultrasound, chest X-ray, if available, whole body PET CT scan is available because it will pick any mets if possible. So divide your examination into 3 parts so that you don't miss in any lid tumor. You even if it is benign looking, you can at least say that since it is benign looking, I would not go for it. But if this were a suspicious lesion, I would also like to do a regional examination and a systemic examination if required. I think that would close the examination. Viva. I think that's it. Anything else, Pallavi?
Another thing is downgrading of staging of tumor, sebaceous gland carcinoma by neoadjuvant is also a important point that we discuss in various forum. So I do not have much experience on this until I just have a few cases I had done excision after neoadjuvant chemotherapy, 5-FU cisplatin. So what is your experience, Dr. Puneet and Dr. Pallavi? Neoadjuvant chemotherapy in sebaceous.
So at AIMS, Dr. Rachna and Dr. Neelam had this series that they were working on, but specifically for sebaceous cell neoadjuvant, and it was very helpful, especially in two types. I think one, large size tumors, and B, recurrent. You know, if you've already done an excision once, and if it's recurrent, then of course, then maybe technically it also becomes adjuvant. I don't know, but if it comes back again, then of course that's the thing. And that's again a very important exam question also, because this is exactly the question I was asked in my final viva. Now I'm getting deja vu, because I remember Dr. Neelam was there, and the question she asked, and I'll say that I mean, I'll repeat that because maybe it might be helpful for the resident. She was like, you know, the patient has a sebaceous cell carcinoma, tumor, vision is 6/6, orbital, and there is orbital extension. So what will you do? So my answer was exenteration, but she said the patient vision is 6/6. There's nothing else you can do. So it didn't strike me at the time, but what she wanted to hear was neoadjuvant chemotherapy. So this is one thing, like when you're answering also, you have to keep it in mind that if an examiner is asking you and you keep saying exenteration, do you think that maybe we'll put in some chemo or radio, you know, because more often than not, even if you don't know about it, I'm sure there is some study somewhere going on, you know, which is talking about different techniques. But definitely in sebaceous cell carcinoma, it is a proven treatment modality we use pretty often. Dr. Puneet, if you have anything to add.
No, absolutely correct. I think that got published eventually in 2018 or 19. I'm not sure. Neoadjuvant chemotherapy in sebaceous gland carcinoma. I think that's a very good article to read. I think I read it a couple of times when I was managing, because in a corporate practice, you get, single couple of patients a year where you need to apply all these things. So I think we missed that point in our discussion earlier. It's a very relevant question in exam as a theory question also. How do you manage? You have a separate, a single page written on this, and then also in Viva. Yes. I think the PG should read it up. Neoadjuvant chemotherapy in sebaceous and eyelid carcinoma. There are good articles available, very straightforward, direct, which you can quote and you write in the exam also.
I think we've had a fantastic discussion. Anything else that you would like to ask, add, Dr. Puneet? Dr. Joyeeta, if you have any other comments that you would like to add. So, I think we've had a fantastic discussion. Thank you so much, ma'am. I think it was very helpful for the residents, because this is a long case question. And I feel oculoplastics more than anything else seems a little scary to most residents, because maybe they don't get as much exposure, or for whatever reason. But I think it's if you just think logically, like how you explained in your slides, it's beautifully. So if you think logically, I think there's nothing to be afraid of and can be very easily done. Thank you so much, ma'am. I will just Dr. Pranita is not here right now, but I will just share my screen. So I think the DOS is my screen visible?
It is visible, yes.
Okay. So I think the winter DOS conference is happening on the 23rd and 24th of November, and the abstract submission has been extended till the 30th of August. So for 5 more days now, and the resident abstracts and the faculty abstracts are separate. So there are 2 different categories. One is for faculty, and for the residents, there's a separate category for presentations. So I would encourage all the residents to submit their abstracts, because there are high chances of acceptance. And yeah, I think that's it. We also have the next class, Dr. Sahil. He's going to be talking about eyelid reconstruction. This is on the 29th of August, which I think is the logical next step to the class we had today, because today we talked about the pathology, and in the next class we will talk about management. I think it is a wonderful class, very useful, important for exams and important for practical life making decisions. So please make sure that you attend. And thank you so much for being with us. Good night. And thank you, Joyeeta ma'am. Thank you, Puneet sir.
Good night.
It was
Thank you.
fantastic having you both.
Thank you,
Happy
Dr.
Janmashtami. Happy
Yes, happy
Janmashtami.
Janmashtami.
Jai Shri Krishna.
All right. Looking forward
All
to
right, thank you.
Okay.